All right, so I'd like to introduce Dr. Kristina Young. She is a radiation oncologist with Providence Health and Services. And I'll just read a little bit from her bio that I was provided. So Dr. Young grew up in a small beach community in Southern California, playing soccer, running cross country, and pole vaulting during track season. She attended the University of California at Los Angeles, where she obtained her Bachelor's of Science in Chemical Engineering. And during her time at UCLA, she was heavily involved in the Bruin Bell Service Association. And then upon graduation, she moved to Portland and began the combined MD PhD program at Oregon Health and Science University, where she met her husband. And then after graduation, she attended Providence St. Vincent Medical Center for her internship, and then completed her residency in radiation oncology at Oregon Health and Science University. So Dr. Young, it is all up to you now. So I'm going to mute and just continue to let people in the room. Thank you so much.
Yeah, thank you so much for having me. I mentioned that my talk will go through some of the new technology that we have at the Providence Cancer Institute around our MR-Guided Radiation Therapy program and indications in breast cancer. But there is plenty of time for questions, so looking forward to hearing what everyone thinks. So to get started, for those of you that aren't aware of what radiation is, this is a little bit of an overview. So radiation that is used for therapeutics, so radiation therapy, is high energy X-rays or gamma rays. And so what I've shown here is the electromagnetic spectrum. So there are waves of different sizes that lead to radio waves, microwaves, infrared waves, visible light, ultraviolet light. And then when you get to the higher energies like X-rays and gamma rays, those are sort of at the far end of the spectrum. And so that's what we see here. So with radiation, you don't see anything or feel anything. How does radiation work? So traditional radiation is delivered in small daily doses on the order of about 2 gray. And they're given Monday through Friday over the course of anywhere from 3 to 6 weeks of daily treatments. There is a newer term for sort of hypofractionated radiation, which stands for fewer treatments. So hypo means less, and fractions are what we call the daily treatments. So hypofractionated means fewer treatments. Often these are sort of broken up a little bit arbitrarily into like the size of the dose. So high dose per fraction radiation that's sort of ultra hypofractionated are things that are over 5 gray per fraction. And typically these are fewer fractions. So the shortest possible fractionation is a single fraction, and that's considered radiosurgery because it's all in one go. There's also, anything from 2 to 5 fractions can be considered stereotactic body radiotherapy or SBRT. Some people call this ablative radiation or SABR. There's lots of different acronyms for it. But those are sort of the different varieties of radiation that we deliver. So radiation with our X-rays causes very well-targeted, effective, localized cell death. And the way that this is thought to occur is through DNA damage. So the radiation causes DNA double-strand breaks, and with the addition of oxygen in the cells, that damage is made permanent or called fixed. And once you get those double-strand breaks, when the DNA tries to repair itself, your healthy tissues can repair that damage with its DNA damage repair mechanisms that are intact. And that takes about 6 hours. But cancer cells innately have deficient DNA damage repair mechanisms. And so that damage tends to accumulate in the cancer cells. And so when we're breaking up the radiation into these small doses over many days, we're trying to exploit that difference and allow the healthy tissues to heal while causing irreparable damage in the cancer cells. And so over time, that sort of difference becomes of larger and larger magnitude. And eventually, all of the cancer cells, when they attempt to divide, they die. And that's called sort of a replicative or mitotic death. And so that's just shown further here. So you can see these little rings are supposed to represent the chromosomes. When they have breaks in them, they sort of make these abnormal fusions between chromosomes that are unwieldy and aren't appropriate. So when cells divide, everything's doubled, and then it sort of polarizes, and the cells try to sort of pull apart. And when they have these rings that have been created by DNA damage breaks that have been repaired incorrectly, they kind of rip themselves apart at the attempt to divide. And so that's what we call mitotic catastrophe. And so that's how the DNA damage from radiation tends to kill cancer cells. So what is radiation used for? So most solid tumor-based malignancies involve radiation as part of the treatment. This can either be used in the definitive setting, it can be used after surgery, which we call adjuvant, or it can be used palliatively, so in an attempt to relieve symptoms in either a metastatic state or a symptomatic state. So definitive radiation is often seen in things like head and neck cancer, anal squamous cell carcinoma, and things like lung cancer. After surgery is very common for breast cancer that we use radiation. And so that's sort of the adjuvant setting. And palliative radiation, we often will use for treatment of things like bone metastases and brain metastases, or things like lung metastases as well. So the rationale for radiation in breast cancer in the definitive setting, so in localized breast cancer, is in the post-operative setting or the adjuvant setting. Radiation is used to help reduce the risk of recurrence by trying to eradicate any microscopic residual disease after surgery. So the most common time that we use radiation is in the post-lumpectomy setting. There are exceptions to that, but that tends to be pretty common. Or things that would lend a higher risk for recurrence. So when you have a breast tumor, the tumor can drain to the lymphatics through these small lymphatic vessels. And if cancer cells get into those lymphatic vessels, you're at a higher chance for recurrence after surgery. And so the pathologist, when they look at the tumor specimen after surgery, will comment on whether they see cancer cells in those lymphatic vessels, and they call this lymphovascular space invasion. So that's something that puts you at a higher risk for recurrence, which may push us to offer radiation. If your surgical specimen has tumor cells that reach the edge of the specimen or very close to the edge of the specimen, we call those close or positive margins. That also often will increase our likelihood of recommending radiation. If you have lymph node involvement at the time of surgery, then we'll often make a recommendation for radiation because we know that that portends a higher risk for local recurrence. Or if your tumor is what's considered locally advanced, so it's maybe growing into the skin or the chest wall, invading sort of another sort of tissue space outside of just the breast tissue, then we often will recommend radiation as well. So a very special subset of breast radiation is called partial breast radiation, and it's specifically intended for patients with very low risk breast cancer after they've had lumpectomy. So typical radiation fields encompass the entire breast and sometimes the regional lymph nodes. But if you have a very low risk breast cancer, sometimes we can offer just targeting the lumpectomy cavity and a small rim of tissue surrounding that lumpectomy cavity. And that's what partial breast radiation is. And there are specific guidelines set forth by radiation societies and the surgical societies that have determined what sort of the people who are eligible for partial breast radiation should be. And so those are listed here. So for patients that are 50 or older, who have negative surgical margins by at least 2 millimeters. So again, that's when the surgeon takes out the tumor, and then the pathologist looks at it on the microscope and they see where the edge of the tumor is relative to the edge of the specimen that was removed. So if that's at least 2 millimeters, then patients are eligible for partial breast radiation. If the tumor is less than 2 centimeters, So that's the T1 stage. Or if it's pure DCIS is the TIS stage. So DCIS is allowed if it was detected by screening mammogram. It expands for less than 2.5 centimeters in total in the specimen. And it's low to intermediate grade. So the grade is what the pathologists give. For DCIS, it's low, intermediate, or high grade is a scoring system based on how abnormal the cells look under the microscope to the pathologist, with low grade being sort of the most normal and high grade being the most aggressive or abnormal appearing cells. So for being eligible for partial breast radiation, you have to have sort of the less aggressive looking DCIS. And for DCIS, they require slightly larger margins of 3 or greater millimeters. So here's just a visual depiction of the target differences between whole breast radiation and partial breast radiation. So on the left, you can see the whole breast tangents. And so this is a screenshot of a radiation treatment plan. So what you're looking at is a CT scan with the dose distribution of the radiation overlaid on top of the CT scan. And so on the left for the whole breast tangents, the top panel is a view as if someone's lying down on a table and you've sliced them like a loaf of bread, and you've pulled up a slice and you're looking from their feet towards their head. So there's like a little green man in the corner and you're looking through the man's feet towards their head. So that shows you the orientation of the person. So this is the left breast of an individual. There's also a little indicator here of an L and an R to show you left versus right. And what you can see here are the different doses on the left. And so this prescription is for 4,500 centigrade. And so that's the orange line, and it's surrounding the breast tissue here. And so you can see basically when we are treating whole breast, we treat from the mid sternum to the mid armpit, from the collarbone to about a finger below the breast tissue. The bottom panel on the left shows you sort of if you're looking face on view of the person. And so you can see it's the isodose, the dose prescription goes basically from the ribs external to that. So we're basically covering all of the breast tissue external to the ribs. On the right, in contrast, is a typical plan for partial breast irradiation. And what you can see drawn in green is a lumpectomy cavity. And then there's a small margin put on that in sort of this lighter blue shade. And that's the target. So instead of treating the entire breast, it's just the lumpectomy cavity with a small margin of tissue around it. Again, these are 3 different views. So the upper left panel is an equivalent view to the upper panel on the left. So this is like looking from a person's sort of feet towards the head, looking in sort of the slice of bread view. And then the lower panel is consistent with the lower panel on the left. So this is sort of a face-on view. You can see sort of the ribs along here, and then this sort of black space in the middle are the lungs. And you can see it's a much smaller target volume when we do partial breast compared to when we do whole breast radiation. So the way that we design the radiation fields for traditional radiation are using 2 beams that we call tangent fields. And so when patients are treated, they're typically lying on their back with their arms above their head. And we have 1 beam that comes from the inside and 1 beam that comes from the outside to cover that volume that I talked about, with from the collarbone to a finger below the breast and from the sternum to the mid armpit. So there's sort of these, they skim diagonally across the chest wall, and that's why they're called tangents. So what you can see in sort of this skin rendering drawing of a patient's treatment plan is what a typical field volume would look like for the target. So it's sort of, this is sort of the breast, and then out into the axilla, it covers some of the upper lymph nodes in the armpit that would be at risk as well. These treatments, when we do tangent fields, tend to be daily treatments, Monday through Friday. The majority of the time, patients are getting these treatments for anywhere from 3 to 6 weeks. This has sort of been the standard for maybe the last 20 to 40 years. for breast treatments. And this is just a nice view of, so this is a depiction of what the beams look like. So this is the one beam that comes from the inside, and then this is the one beam that comes from the outside, and they sort of meet in the middle and cover all of that tissue. So one nice thing about doing the partial breast radiation is that there's that smaller target volume, but sometimes that can be challenging to visualize using our traditional CT-based detection methods, which we use for our planning scan. And then for our daily treatments, it can be very challenging to identify where the lumpectomy cavity is, because we use very low dose CT scans on a daily basis for treatment alignment purposes. And those have a very poor job of soft tissue discrimination. So one benefit to using MRI to guide breast radiation is for better visualization of the lumpectomy cavity. So what you're looking at in this slide is 3 different views of a lumpectomy cavity using an MRI. And so what you can see shown in the arrows is the lumpectomy cavity clearly displayed with a black sort of rim around the edge of it and a fluid-filled white center shown here. And so that would be very easily identified for your planning purposes, and then also for your daily treatments, because this is the quality of the scan that you would see each day when we would obtain the alignment imaging. So as I mentioned, there's multiple sort of criteria for patients to be eligible for partial breast radiation. There's also multiple ways to deliver partial breast radiation. So up until recently, the majority of those ways were a lot more invasive than traditional external beam radiation. So often we were using brachytherapy to deliver partial breast radiation. And so brachytherapy requires the insertion of a device into the lumpectomy cavity. And so that's shown sort of schematically here on the upper right of the screen. And so this is one of those brachytherapy devices where it's essentially a balloon or almost like a whisk that can be flattened, and it's inserted through a small incision that's about the size of a centimeter or so into the lumpectomy cavity, and then is deployed. So it starts flat and then can be expanded to fill the volume of the lumpectomy cavity. And then sort of over here is what a cross-sectional view looks like through that expanded brachytherapy device. And so each of those sort of wires on the whisk is a hollow tube, and we're able to pass a radioactive source sort of down the tube and have it deliver radiation very focally around the lumpectomy cavity. And so with the brachytherapy partial breast treatments, that device is placed and stays in the patient for about 2 weeks typically. Radiation is delivered twice per day over 5 consecutive days, and then the device is removed. For a lot of patients, it's not comfortable to have that device in place. And our cosmetic outcomes with that device had been less than ideal for some patients. There's also limitations to the use of that device based on where the lumpectomy cavity is located. So if the lumpectomy cavity is too close to the chest wall or the skin surface, they would not have been considered eligible for this type of radiation treatment. So in order to sort of get around some of those limitations and difficulties, people evaluated whether we could use external beam radiation with sort of less advanced treatment planning techniques, which we call 3D planning, and looked at similar dosing regimens as the brachytherapy device. So still 2 treatments a day, so 6 hours apart. So 1 in the morning and 1 in the afternoon, Monday through Friday for 10 treatments total, and followed those women for their likelihood of recurrence and cosmetic outcome, meaning like development of scar tissue, contraction of breast tissue, and found that with that external beam treatment, while cancer control was equivalent, the cosmetic outcome was quite poor. And so people sort of were shying away from that as a treatment modality because it didn't seem like it was equivalent to whole breast radiation. More recently, technology in radiation has advanced, and so our treatment planning techniques have gotten more sophisticated. And so people have tried to use external beam radiation with more advanced treatment planning techniques termed IMRT, or intensity modulated radiation therapy. And one of those plans is shown at the very bottom. And this type of radiation planning allows for the radiation dose that's prescribed to more tightly fit the volume that we're prescribing to. But with these techniques, they were able to deliver just 5 treatments of radiation, so 5 days in a row, instead of doing twice a day. So they could give a little bit more dose per day, per treatment over fewer treatments. So 5 treatments in total. And they found that that patients who went through this had equivalent control of their cancer, and the cosmetic outcome was very similar to doing whole breast radiation. And this type of radiation can be delivered on a standard linear accelerator, which uses our sort of CT guided approach, or on our MRI guided approach using our MR-Linac. So in terms of imaging tumors, we're going to get a little bit into the details because I think that's really important to highlight why MR-guided radiation is superior. So for imaging tumors, we can often use CT scans, and we do that for the vast majority of treatments that we do in our department. The benefit of CT scans is that they're very fast, and you get some good soft tissue visualization compared to like X-rays, but it does leave something to be desired for certain parts of the anatomy. But it is by far the most common treatment planning modality for radiation. The benefit of MRI is that it gives you the absolute best soft tissue visualization of any of our imaging modalities. The drawback is that it is more time consuming. And it is a little bit more claustrophobic for folks that have issues with claustrophobia because it requires you to fit inside a more narrow bore than our large bore CT scanner. And then finally, many people are familiar with PET CT scans. Those are often, the PET component of them is, it stands for positron emission tomography. And the PET portion is fused to a standard CT scan. So you get the visualization of a non-contrast CT scan of your anatomy. And then overlaid on top of that is some biologic information. So the most common radio tracer that we use for PET scans is radio labeled glucose. And so that tumors that are more metabolic, that are growing faster, take up that sugar more than other parts of the body. And so it provides that biologic information of where there's more aggressive tumor growth or where there's more likely to be a tumor based on the fusion to the CT scan. But the visualization of the underlying anatomy is still based on the CT scan, and the registration of the PET data, so the overlaying of that biologic information onto the CT scan, will require for accuracy that the patient not have moved at all during the course of the PET portion of the exam. And that PET portion can actually take quite a bit of time, like 20 minutes or so. And so it can be kind of challenging. Sometimes you'll see a lot of movement, or there'll have been a shift in head position or body position between the PET scan and the CT scan portion of those, so that sometimes don't have accurate alignment, which can limit some of the information that you can gain from it. So just so that you have in your mind what the MRI guided radiation machine looks like, this is the same machine that we have in our department. This is not from a picture from our department. This is a stock photo, but this is what our machine looks like. So you can see in sort of the blue here, this is where all of the magic happens. So this is a it has the MRI component. So this is a big magnetic coil, and then also has the linear accelerator components in it. And so the patient will lie down on this table and sort of slide into that bore. And so that's what I was mentioning about sort of issues with claustrophobia, is the patient is pretty much fully inside the tube of the MR Linac for the treatments and for all of our planning sessions around that. So in terms of timelines for radiation, I did a little bit of a comparison for you between traditional radiation medicine, radiation planning, and MRI-guided radiation. So the different components of your course through the department are sort of shown here. So the very first appointment that you would have if you've decided to pursue radiation is called a simulation appointment or a planning session. And for traditional radiation, that takes about 45 minutes or so. At that appointment, we sort of make a mold of your body to make sure you're in the same position for each and every treatment. And then we perform that CT scan that we use to plan your treatment specific for you and your anatomy. You get a couple of tattoos at that appointment, which we use for alignment each day when you come in for treatment. That's sort of what's entailed at that appointment. For MRI-guided radiation, that appointment takes about 90 minutes because we use both a CT scan for density information about like the tissue density of your body, and we do an MRI for information about tumor location and gating of your tumor during your respiratory cycle. And so because you get both an MRI and a CT scan, it takes about twice as long. In terms of planning time for traditional radiation, it usually takes our dosimetry team and our physicians together about 2 to 3 days to come up with a standard treatment plan for traditional breast tangents. With our MRI-guided radiation, it is that more complicated treatment planning method that I showed you a few slides back, where the treatment, the prescription sort of radiation fits very tightly around that lumpectomy cavity. And to get that sort of very nice sort of shape right around our target takes a lot more planning effort and time. And so that takes around 10 to 12 days for our team to plan. After we develop any treatment plan, we are reliant on our brilliant medical physicist team who make sure that the plan that we've come up with is actually able to be delivered on our treatment machines. And that takes them a couple of days to run through all of the quality assurance that they do to make sure that our plan is safe and deliverable. And then our final step is actually treatment delivery. So basically from simulation to treatment delivery, that's all things that happen behind the scenes. You've gone back home, you're not in the department for those, but this is treatment delivery is, when you come back for the radiation to be delivered. And for our traditional radiation, each daily treatment delivery takes about 10 or 15 minutes, but you do that somewhere between 3 and 6 weeks worth of treatment. So that 15 to 30 treatments. For MRI-guided radiation, each day when you're in the department, we're doing an MRI for localization. We're gating your treatment based on your respiratory cycle and the tumor positioning relative to your normal tissue anatomy. So that treatment each day takes about an hour, but we're only doing it for 5 treatments. So there are some different time commitments based on what type of radiation you're interested in receiving. So the benefits of MRI guidance in treatment planning is that we get much better visualization. So we're able to have more accurate target volumes. We don't need markers or fiducial placement. We're able to see the tumor itself in real time. We are able to have more accurate volumes for organs at risk. So anything we're not intending to radiate that is a normal tissue that's nearby, like your heart or your lungs, is what we consider an organ at risk. And so we're able to have really more accurate volumes for that, particularly when we're targeting things in the abdomen. So small bowel can be very challenging to visualize on our regular linear accelerators. But on the MR-guided machine, it's very clear when we're looking at stomach and small bowel and large bowel. So we're able to get more accurate volumes for those organs. And because of that better visualization, we're able to put smaller margins on our targets. So that means we're radiating a smaller volume of tissue, and we're able to then deliver higher doses of radiation over fewer treatments. So just for sort of a visual schematic of that, I'm comparing a cone beam CT guided radiation, which would be what we use on our standard linear accelerators, compared to our MRI guided radiation on the right. And so if you just take a look at the schematic, you can see that the visualization of the tumor on the left is not quite as clear. And therefore we have a larger margin on that tumor for what's being treated. And then in gray is some normal structure that we are trying to avoid. And so we have to plan for a little bit of an extra buffer on that normal tissue to prevent damage to that organ. So we sort of can't account for motion in real time. So we give ourselves a larger buffer on dose we're able to deliver, and a larger buffer on the volume that we're able to target. So this is sort of explained in each of these points. So you can't see the tumor boundaries as clearly. It causes a larger dose distribution area. We're not able to see those surrounding organs as well, which makes alignment and targeting more challenging. Cone beam CT that we do each day for alignment is a low dose of radiation to the patient. It's not much, but it exists. And the image quality is more poor. So for certain target areas, we end up having to place fiducials or implants to visualize things more clearly, like in the prostate. But we're not talking about that today. With MRI guidance, the tumor borders are much clearer and more crisp. We have better image quality, which allows for smaller margins. So our target volume is smaller. We're able to track anatomy in real time. So if, with respiration, the tumor is moving, we are able to track that. We're also able to track if, say, you swallowed some air and your stomach sort of gets close to the area that we're targeting, we can turn off the beam while that bubble of gas passes by and not cause damage. The imaging that's done on the MRI does not add dose to the treatment because MR imaging is not a source of radiation. And finally, imaging during treatment is possible with MR guided radiation. So you don't need invasive markers, and you can actually watch the tumor during the treatment delivery. So you can track any motion that's happening and know that you're hitting your target while the radiation is being delivered, which you can't do on a standard LINAC at all. What you can see here is just an example of soft tissue visualization that we get. This is an example of a prostate. So what you're looking at is a side view of someone's pelvis. And so on the left is our traditional cone beam CT guided radiation visualization. And on the right is MRI guided radiation using the MR LINAC, the Meridian that we have in our department. And so you can see, this is the sacrum here, that's the bone. What you're looking at here is a bladder, and this is sort of the front of the bony pelvis. And the prostate sits somewhere in this sort of light gray haze without clear visualization. And then this sort of snaking bit here is the rectum coming through, and it has some bowel gas, so you can see it a little bit on this scan. If you look on the right, this is the MRI image. And so you can see that same sacrum, that bony anatomy. You can see the same bladder here, and you can see the rectum coming here. But what's really impressive and clear is that you can clearly visualize the prostate. And what you're seeing here is also the urethra as it passes from the bladder through the prostate into the penile urethra. And so you have so much clearer visualization. You can see that the margins on that prostate can be smaller, and you can track in real time, as the bladder fills, as the bowel fills, whether there's motion of the prostate, which it does actually move. So you can actually be much more accurate, and you can feel much more confident in what you're targeting using the MR guidance. So this is another example of one of the benefits of MRI-guided radiation. So each day when the patient comes in for MRI-guided radiation therapy, we perform an MRI scan on the machine, and we adjust our target based on the anatomy of the day. So this is an example of a pancreatic tumor. So the pancreatic tumor is shown sort of in this orange highlight. And then what's coming off around that is the different radiation doses. But in these other shaded colors are the organs we're trying to avoid. And this is what I was saying earlier about, because we can clearly visualize loops of bowel each day, it makes it a safer modality, and we can get more dose in using the MR guided radiation, because you can see from day 1 on the left, day 2 on the right, the alignment of where the tumor is relative to where the bowel is in pink and blue and orange is different from day to day. And if we're not using the MR Linac, we can't clearly visualize those structures and avoid them each day. So what we end up doing is treating to about half the dose of what we can actually deliver on the MRI guided machine. So with the Meridian, we're able to each day adjust our target volumes. We're able to adjust our organs at risk. And then we're able to more accurately visualize those things. And so we can target our tumor better and avoid the things we don't want to radiate better. And so it really is a game changer for us for some of these types of treatments. So this is an example of how we can use the MR guidance during delivery to gate the treatment. So as patients are sitting on the treatment table and breathing as we normally breathe, our chest expands and contracts. So a breast tumor actually moves during respiration. So one of the reasons when we're doing partial breast radiation with external beam radiation, we have to give these margins to account for tumor motion, because we can't visualize it when we're using a standard Linac, and we can't account for that. So we give sort of a motion bubble, a margin on the lumpectomy cavity to account for that. But there's been good data that when we use MR guidance and track the tumor and gate on the tumor, we can use much smaller margins because we don't have to account for that motion. And so this is sort of a side view of the lumpectomy cavity, and what you see drawn in red is the target, and in yellow is our motion envelope that will allow radiation to be delivered while the target is in that yellow contour. And as the patient breathes and the target moves out of that contour, the beam turns off. And as it goes back in, the beam will turn on. And so I think I had a video of this, but it didn't embed properly, so you don't get to watch it, and I apologize for that. So in terms of what to expect from side effects from radiation, this is from the ASTRO website. So this is the National Organization for Radiation Oncology. This is their patient material for what side effects you might expect when you undergo whole breast radiation. So short-term side effects are shown in sort of the red bubbles, and long-term potential side effects are shown in the green bubbles. And the more likely side effects are the larger bubbles and shown on the left side of the screen. And then the less likely side effects are in sort of the smaller bubbles with less coloration to them on the right side of the screen. And so I think for patients that are going through treatment, the most common radiation side effects are skin redness and fatigue. And the degree to which patients get those is highly variable, but it's somewhat unavoidable. It's pretty rare that someone will get through treatment without some skin redness and some level of fatigue. There are other sort of potential side effects that are much less likely, and those are shown towards the right. Long-term side effects of whole breast radiation, I think the most common things are changes to the consistency of the radiated tissue. So the breast itself can feel firmer. It can cause a decrease in the cup size of the breast. There's a development of sort of scar tissue, which is what that firmness is. You're at a higher risk for developing lymphedema, so that's shown as arm swelling on here. And long-term, you can have changes in the skin itself. So it can be darker or thicker or firmer long-term. With partial breast radiation, we eliminate many of these side effects. So many of the very low likelihood side effects just aren't things that we see with the partial breast radiation. You're not going to be getting lymphedema. You're not going to be getting many of these side effects because the volume that we're targeting is just that much smaller. Is it possible that you'll still get some fatigue and skin redness? Yes, but it will be to a much lesser degree. So the level of fatigue is likely to be less. The level of the area that you'll be getting skin redness will just be overlying the lumpectomy cavity, not the entirety of the breast tissue, not in the armpit, not underneath the breast. As we've been doing more of these treatments, we really see that there's very minimal, like you really have to squint to see if there's any pinkness on the skin. Like it's just a much more subtle, much better tolerated treatment when patients are going through it than what we see with traditional whole breast radiation. In terms of long-term side effects, those side effects of scarring still remain, and the long-term follow-up on sort of whether that's going to be reduced with MR-guided partial breast radiation is a question that is of interest to us. So for the patients in our department that are interested in getting partial breast radiation treatments on our MR-guided machine, we do have a registrational study open so that we can follow patients to make sure that their cancer control is as expected, but also to see what the long-term cosmetic outcomes are with this type of radiation. So we're doing some scoring of like the development of scar tissue and whether there's any changes in breast size or breast contour following partial breast radiation on the MR-Linac. And so that's a question that we hope to be able to answer. I think other institutions have been looking at this as well, and the early results are really favorable. And so we're just hoping to add to that body of literature and make sure that, what we're offering is, better than what the standard is that's available now. So just to sort of sum up what some of the pros and cons might be of MR-guided radiation therapy. The pros are we're able to treat smaller target volumes. And that's because we can see the tumor cavities much better. We're able to be very precise in our targeting, and part of that is because of that visualization, and part of it is because we're able to track in real time as patients are breathing, that we can actually decide when to turn the beam on and when to turn the beam off, and we can be much more precise in what we're treating. Because of that, we have the potential for fewer side effects. And in addition to sort of our registrational study, we have an ongoing quality of life study to ask this question from a patient perspective, to try and have your feedback on what your experience is going through radiation treatment. And this is open for patients with breast cancer treated with radiation across any modality. So this includes patients who are getting standard whole breast radiation and patients who are getting MR-guided radiation therapy. And we would like to compare the patient experience going through each of those to see if we can truly say in an unbiased way that patients do better, have a better quality of life when they're treated on the MR-Linac. And finally, the duration of treatment. So 5 treatments of radiation in total with the partial breast radiation is significantly less than what we do for the majority of our whole breast treatments. So some of the downsides of MRI-guided radiation therapy is that while there's fewer treatments, each treatment takes a longer time to deliver. So your standard treatment probably takes on the order of about 15 minutes, but for an MR-guided partial breast treatment, I would estimate at least an hour for that treatment to be delivered for most patients. Another limitation is that you must be able to get an MRI in order to get this treatment. And so that really limits us to patients who don't have any pacemakers or magnetic implants or devices, and patients who are able to lie flat for about an hour with one arm up, as we do for most of our breast treatments, and who aren't claustrophobic or have limited claustrophobia that can be managed with medications. So those are some of the sort of pros and cons. And if you'd like to learn more about that, there's a link at the bottom of the page that can take you to our website so that you can read a little bit more about the different types of radiation that are offered in our department. So that really concludes the bulk of my talk. There are many people that were extremely helpful in getting this program off the ground. And we're very grateful to Elsie Franz for her very generous donation that allowed us to obtain our MR-Linac through her generous support of the Providence Foundation, and with the rest of the outstanding team in the radiation oncology department, and our wonderful Meridian team that we have here, who put in really impressive hours and dedication to learning this novel technology and how to implement it in a community clinic. We were the first MR-Linac in the Pacific Northwest, and the first in a community center. And so it was really such a phenomenal effort to be a part of, and I'm just really grateful that we were able to bring this technology to our patients and provide them with this opportunity for what I think is the future of radiation. So thank you very much for your time.